Buongiorno a tutti, benvenuti al webinar del Consorzio Universitario Humanitas, una nuova prospettiva sul burnout, ricerca e applicazioni in assistenza sanitaria. Introduce la professoressa Chiara Consiglio, a seguire il professor Sciofeli.
Ok, bene, benvenuti, benvenute. Allora, io sono Chiara Consiglio, appunto sono professoressa associata presso il Dipartimento di Psicologia della Sapienza e appunto è un mio grande piacere oggi introdurre questo webinar del professor Vilmar Sciofeli e dirò appunto due parole per presentare il suo, diciamo un po' brevemente, anche se ovviamente, insomma, ha una carriera lunghissima ed è uno dei più noti studiosi, insomma, nel nostro settore, nell'ambito della psicologia del lavoro. Allora, il professor Sciofani, appunto, come dicevo, è uno degli studiosi più prestigiosi, è professore emerito presso l'Università di Utrecht, Distinguished Professor presso l'Università di Leuven in Belgio, e appunto ha una lunghissima carriera alle spalle, insomma, che porta avanti anche tuttora, diciamo, nell'ambito in particolare del benessere organizzativo, della salute all'interno dei contesti di lavoro. Si è occupato per moltissimo tempo di burnout, ma anche di engagement, quindi anche degli aspetti positivi, quindi del coinvolgimento dell'energia nel lavoro e ha portato un contributo nella nostra disciplina davvero insomma, di grande valore, sia sul piano concettuale, teorico, che sul piano metodologico, che anche sul piano dell'intervento. Si appunto è autore tra l'altro di oltre 500 pubblicazioni scientifiche, tra l'altro svolge anche attività di consulenza, quindi è partner e fondatore di una società di consulenza che appunto si chiama People I HR Human Capital, scusate, Tribal I Human Capital appunto proprio per provare a fare questa connessione tra ricerca scientifica e applicazioni pratiche, quindi con l'intento quindi di promuovere all'interno delle organizzazioni l'engagement e appunto utilizzando un approccio scientifico e appunto e solido da un punto di vista metodologico. Ehm, Recentemente lui, tra l'altro, è uno degli autori che ha costruito, che ha validato l'MBI, quindi lo strumento, diciamo, forse più noto a tutti per la misura del burnout, ma in realtà più recentemente ha avviato, diciamo, ha promosso, ha costruito e appunto ha avviato la validazione a livello internazionale di un nuovo strumento che si chiama Burnout Assessment Tool, di cui penso insomma parlerà sicuramente anche oggi, fondando proprio un consorzio internazionale per la promozione e la validazione a livello internazionale di questo strumento, di cui tra l'altro anche io faccio parte per quanto riguarda l'Italia insieme a una collega. Abbiamo quindi anche noi validato la versione italiana e quindi diciamo che questo è stato un ulteriore contributo in termini di innovazione rispetto appunto nell'ambito del burnout. La cosa che insomma che sottolineo e che mi sembra anche un elemento di particolare rilievo è il fatto che il professor Sciofeli cerca proprio anche di conciliare rispetto alla lettura del burnout, una prospettiva organizzativa, ma anche con una prospettiva collegata anche con implicazioni di carattere più individuale, più clinico. Ehm, Diciamo che ecco, ai fini insomma anche dell'intervento di oggi, dico che lui si è occupato anche molto appunto del burnout in ambito sanitario, quindi della prevenzione del burnout, dello sviluppo dell'engagement e della salute proprio nei contesti specifici anche di carattere sanitario. E quindi appunto direi che insomma come introduzione mi fermo qui, poi lascio la parola a lui, quindi è con mio grande piacere che insomma introduco appunto e lascio la parola al professor Schofeli. Dico soltanto appunto, ripeto questa cosa per quanto riguarda la lingua, il suo intervento sarà in inglese e quindi chi preferisce di voi può scegliere ovviamente il canale italiano per sentire la traduzione simultanea, oppure può scegliere di sentire la versione originale e quindi sentire direttamente la versione in inglese. Grazie a tutti. Ah, ecco, aggiungo solo una cosa. Noi abbiamo previsto un quarto d'ora di question time, quindi per le domande, proprio per facilitare anche insomma, uno scambio, un minimo di interazione, quindi se avete delle domande le potete sia scrivere nella chat adesso o tenere per la fine, ve le faremo comunque tutte quante nella parte, alla fine, in chiusura insomma, del webinar. Grazie.
Well, thank you very much, Chiara, for this nice introduction in Italian. I didn't understand anything.
No.
Sorry, I did understand some of the things, and the things that I understood were very nice. Well, thanks also for the organizers to give me the opportunity to talk about a new perspective on burnout with a focus on healthcare. Well, let's first have a look at the history of burnout. Many of you might think that burnout is something very new, very recent, but in fact, it is not. This is illustrated by these lines from a poem of William Shakespeare that is connecting burnout not with work, but with love. When you are in love, then you are on fire, so to speak, and when the love is over, then you are completely burned out and gone to ashes, so to say. So the metaphor of burnout as a mental state of exhaustion is already very old. More interesting, perhaps, is that in the 19th century, an American psychiatrist, Miller Beard, introduced the concept of neurasthenia, which literally translates into nervous weakness. And at that time, the reasoning was that there is so much new sensory input to the minds of the people, because there is a telephone, there is a telegraph, there is artificial light, there are steam engines or steam locomotives, steam trains, there is advertisements all over the place. So that is a bombardment of all kind of information. And our nerve system cannot handle that. And therefore, many people are feeling tired, exhausted. And if you read the reports at that time about neurasthenia, you think it's actually burnout. And if you think about the parallel, that's also interesting, because in today's reasoning, the idea is that, well, maybe we are burnout because there is a lot of information on the internet, there is a 24/7 economy, etc., etc. So the reasoning is about the same. It's a kind of overload that people cannot cope with. In the 1960s, the term burnout was for the first time used in this new form by Graham Greene in this novel. It's a short novel. I can recommend it when you travel for 2 or 3 hours in an airplane, and you can almost read it. And more serious research was done by Christina Maslach in her book of The Cost of Caring in 1976, and in 1980 followed by Herbert Freudenberger. And these two figures, Maslach and Freudenberger, they were actually seen as the fathers and the mothers of the new burnout phenomenon. Well, I will touch upon this very briefly, but as I said already, in the connection with neurasthenia, there is also a sociocultural background of burnout. So the idea is that perhaps it is also one of the reasons is that there is an expanding of labeling. So there are many psychiatric and psychological phenomena that are now considered to be a problem that were not so a while ago. For instance, HEDS, the kind of well, syndrome of unrest and young adults or PTSS. These are all kind of new forms of mental problems that have been introduced, and burnout and stress could be one of them as well. Also individualization, so people are more or less alone now, more than they were a while ago. So that means that they have to cope with all kinds of problems themselves. Erosion of the psychological contract means that organizations are asking much more of people nowadays, of effort, of energy that they have to put in, the skills, etc. And on the other hand, the rewards are actually less, because it's in modern organizations it's more difficult to have a career advancement, for instance. And there are high expectations, especially also in healthcare, when young healthcare practitioners, they come for the first time in practice, then they feel that there are a lot of nice things that out there. So professional development, your colleagues are very nice. There is a lot of autonomy in your tasks. You can realize yourself. It's a meaningful work. You can advance in your career. And all these things happen not to be the case. So your colleagues are also competitors. Professional development, well, there is no time because the work pressure is too high. So these people get frustrated. So these are just some ideas about that burnout is not only an individual issue, but it has also to do with the way we organize labor in our society. So what actually is burnout? What are the main characteristics? Burnout has to do with mental energy, as was already shown in the quote of Shakespeare. And you can use that metaphor of a kind of battery. You can say when the battery is completely filled, we call it engagement. So workers are engaged, have a lot of energy, a lot of drive, and they're very enthusiastic about their work. And the opposite is the case in terms of burnout. Of course, there is this exhaustion, this extreme tiredness, but this extreme tiredness also translates into emotional and cognitive impairment, because people are so tired that they cannot control their emotions. So that means that they get angry very suddenly, or depressed, or they lash out, they feel hostile. So they cannot control their emotions, start to cry. They can also not control their thoughts and their cognitions. That means there are attentional deficits. It's difficult to focus, to concentrate, to use your memory. So these are all connected, intimately connected with this exhaustion idea. And then there is mental distance. And this is the idea that because the work is so exhausting, people try to take some kind of mental distance, being not involved, withdrawing oneself, making sick humor in an attempt to distance yourself from the situation. These are examples of mental distance. And then these symptoms are accompanied by a lot of psychosomatic symptoms like headaches, tense muscles, like feeling nauseous, bad sleep, worrying, etc. They're not typical for burnout, but they are associated with burnout. And these symptoms are typically work-related, although there is a discussion that maybe you, as a parent, you can also be burned out, especially when you have teenagers and you have to deal with all that stress. And it is supposed to be a phenomenon in normal persons, which means that they don't suffer from any psychiatric disorder like depression or anxiety. And it is very important to make a distinction between burnout complaints and burnout as a disorder. So we are talking about mild complaints, especially in psychology, and then we consider it to be a phenomenon that had different dimensions. You can be also a little or a little bit more or a little bit less burned out. Psychologists use questionnaires, particularly on people who are still at work, in a kind of audit situation, or a survey in organizations. Concentrate on work factors, risk factors, and try to prevent burnout in organizations. So this is more the psychological way of looking at it. On the other hand, in occupational physicians, occupational health, burnout is seen as a disorder, and it's not something that is dimensional. So you have it or you don't have it. Like you cannot be a little bit pregnant. So you have it or you don't have it. It's a diagnosis. And it's not only a questionnaire, but also a clinical interview. Occupational physicians usually see people that are unable to work, no longer able to do the work. Also, non-work related issues come into play. It might be a divorce, financial problems, problems with your children, etc. And the focus is on individual cases, and you want to treat them and make them better and rehabilitate them so that they can do their work again. So, but it's important to make this distinction, and we will see later that most of the things that we know is about the complaints. We know a lot less about the disorder. And in the public debate, those two, complaints and disorder, they are very often mixed. Well, burnout as a complaint, I think that Professor Consiglio already mentioned this, the Maslow burnout inventory with 3 basic dimensions: exhaustion, cynicism, and reduced competence, is the traditional way to measure burnout. And there is a lot of criticism in this. For instance, it has been developed very early in the 1980s already as a research instrument, so not to be used in practice. This professional efficacy or reduced competence seems to be more of a consequence than as a defining symptom of burnout. The MBI is also incomplete because this emotional and cognitive impairment is not included, and now we know that it is at the core of burnout. It does not yield an overall burnout score, but only on these 3 dimensions, and it cannot be combined, so that makes it more difficult. Norm scores do not really exist, and there are a lot of more technical issues that I don't want to go into right now. So we came up with a different tool, a different way of measuring burnout, a self-report instrument that considers burnout to be a syndrome which has 3 core symptoms, or actually 4. So exhaustion, cognitive and emotional impairment, and mental distance. And you see here that mental distance is a kind of seen as a kind of way of coping, a wrong way of coping actually, because you are so impaired. You try to distance yourself, but in doing so, you aggravate the problems. So you get even more tired. So instead of a solution, this mental distance is a problem. And you have these secondary symptoms like depressed mood, psychological distress, and psychosomatic complaints, which you should also take into consideration, but that are not really the core symptoms. For those of you who are interested, you can visit this website. There is also an Italian version that is available and can be used, and that has been made by Professor Consiglio and her team. So that's burnout as a complaint. But now a step further, burnout as a disorder. So it is not included in the DSM-5, which actually is a psychiatric handbook of the American Psychiatric Association that is used worldwide for diagnosing, or not for classifying, I must say, mental diseases. But it is, since 2021, I think, a part of it is included in the International Classification of Diseases of the World Health Organization. But interestingly, not as a medical diagnosis, but as literally an occupational phenomenon. So this is a little bit ambivalent, because ICD-10 or the 11 actually is a classification of diseases. Burnout is included, but not as a disease, not as a diagnosis. So this already illustrates the ambivalence, actually. It exists, but, well, we don't call it a medical disorder, or we don't call it a diagnosis or a disease. So there is a problem here, because in many countries, I think including in Italy, but certainly in the Netherlands and in Scandinavia, there are people who are suffering from burnout, and there is no official recognition in terms of a medical diagnosis. So the solution was in the Netherlands to have guidelines for the assessment and treatment of work-related stress complaints, and these guidelines were officially issued by the Royal Dutch Medical Association and by the Association of Psychologists. So it's an official document that is also used in practice by physicians and by psychologists, also for diagnosing people with burnout complaints. So in these guidelines, 3 conditions are differentiated. First, distress or job strain. Second, overstrain. And third, burnout. So the distress is actually distress symptoms like worrying, like being not able to sleep, feeling cognitively not very fit. You go to the practitioner, to the health practitioner, to your family doctor, and he's probably describing you some kind of drug or whatever, but you still do your work, but not so very well. And then there is the second stage, so to speak, the second way of looking at it. This is overstrain or temporary crisis. Then the symptoms become so overwhelming that you are not able to fulfill your work role anymore. So you call in sick. Well, we know meanwhile that it costs about 6 to 8 weeks to return back to work, and some counseling and some advice on how to behave and how to adapt your lifestyle and your work situation can do the work, actually. So it's not a very serious issue, but people are not able to work. And then there is burnout. And burnout is considered to be more grave. This is typically a kind of disorder. And the defining characteristic is first that it should be focused specifically on exhaustion. And the second thing is that these complaints, they should last for more than 6 months. And what are these criteria for burnout, for clinical burnout, so to speak? So exhaustion is the hallmark, that's the most important thing. And then at least 3 distress symptoms, like emotional instability, irritability. You see, this is the emotional part, poor concentration, worrying. This is the cognitive part, and disturbed sleep, intolerance of any noise in crowds, and feeling very nervous and jittery. So 3 of these, including not the feeling of not being in control. You cannot solve it yourself, so you need professional help. You cannot fulfill your professional or social roles, and the duration is 6 months. And interestingly, in Sweden, they call this exhaustion disorder. And independently from the Netherlands, they develop actually the same diagnostic criteria. So we have a valid and reliable questionnaire to measure the mild symptoms. And we have criteria also for a clinical interview to measure or to diagnose a burnout as a clinical condition. So how often does it occur? Well, so I present some data from the Netherlands because to my mind, these data have been collected for, well, the longest period that I know from any other country. And here you can see they started to measure burnout, actually exhaustion, from this Maslow burnout inventory. So they used the most important part of burnout, you could say, starting in 1997, and with the exception of a few years, 2004, 2005, they used another instrument. You see that there is indeed an increase. And when we use the burnout assessment tool, and use the criteria that we developed there, then it is about the same. It's about 14%. It's lower when you compare it to Finland and Flanders in these countries when you use the same criteria for the BAT. I come to that a little bit later. It becomes even more interesting when you break it down, for instance, in age. Then you see that the age group of 25-34 has the highest incidence. It's about 20% of all the people, against the total is about, well, a little bit of 16 or so. And when you add women, then you see that especially women in the age of 25 to 34, they run the highest risk on burnout. And the general explanation is that particularly in this period, women have a kind of, let's say, a double load where they have to deal with. They have to deal with the job. They are usually new on the job, starting their careers and starting also a family and having children and all that comes to that. So that means that they are especially vulnerable for that. And here you see it's unfortunately in Dutch, but these are different industries. The top one is onderwijs, which means education, and the second is zorg, which means care. So care professions and teaching professions, they are most likely to develop burnout symptoms. And least is actually agriculture here and construction. So you see that there are meaningful differences between different industries, different sectors in economy. Burnout and COVID. Now there are various studies, and this is just one example, that assess the impact that COVID might have on burnout. And this is a Finnish sample using, I think, 10 or 15,000 people. And they measured burnout before COVID, not knowing that COVID would develop anyway, and followed it up to June 21. And actually what they see is a very, very small increase, but it's statistically significant, but practically so small that it doesn't have any significance at all. When you break it down, you see that burnout in younger age, just as the Dutch data showed, is higher than in older age, and that particularly in the younger group, there is a slight, very slight difference, increase in burnout. But the authors conclude that actually COVID does not have that much of an impact at all on the general population. Well, what about healthcare now? Well, the interesting thing is if you look at prevalence data in healthcare, and I listed here some meta-analysis and systematic reviews, then you see that the prevalence ranges, for instance, in the first meta-analysis of almost 200 studies, between 0 and 81%. So, well, what does it tell us? Or between 2 and 72%, or between 9 and 79%. So this is not really informative. And the conclusion in the paper of the Rothenstein was also that, well, burnout it's not very well defined. The measurements instruments are not very good, especially also the cutoff scores, because, well, you want to classify people in being burned out or not burned out. They are not really good, valuable cutoff scores that can discriminate between both groups. So they all use different ones, and that means that there is a huge difference. The second point is that these samples are by no means representative. So sometimes it are medical residents, sometimes it are only surgeons, sometimes it are, how do you say, first care nurses or ambulance doctors. So you cannot really compare that. And so what we did with the burnout assessment tool, and this paper is recently published, actually this year, we validated clinical cutoff scores also based on scores of patients that were diagnosed using this criteria in the Netherlands and in Sweden to classify people in burnout or not. So now with the burnout assessment tool, we have clinical validated assessment scores that can be used in practice, also to compare levels of burnout disorder in different or high levels of burnout in different medical groups. This is a study that I think is very interesting because it's longitudinal. We followed Dutch general practitioners for 10 years. And what we see here, it is about burnout complaints. So that means that they are not completely burnout, because otherwise they wouldn't work, logically speaking. But they are scoring relatively high on this Maslow burnout inventory. And we see that when you're following up in 5 years, you see that about 42% spontaneously recovers. This is the blue field in the 1996 column. And another 5 years later, 34% spontaneously recovered. But there is a large group that remains in the so-called risk group over the years. So there are general practitioners in the Netherlands, quite a lot of them, about 30-40%, that are working as a general practitioner for 10 years with very high levels of burnout symptoms, but still working, which also shows that this is a serious issue, and it is a chronic issue as well. So now we could have a look at the relation of burnout with work and organization, because we want to know what are the drivers of burnout, what is specific about burnout, and what can you do about that. Well, first of all, burnout is very bad. I will not go into detail because it's more or less self-obvious. It's bad for employees because it is associated with more physical health, physical illness, higher risk of cardiovascular disease, poor mental health, more depression, negative attitudes like low commitment for the organization. But it's also related to very bad outcomes for the organization, because high sickness, turnover, work incapacitation. So organizations need to invest in replacement costs, poor performance, medical errors. It's a study among surgeons and also nurses. It's actually the same. Nurses and doctors who are high in burnout, they are more prone to make medical errors. Also, the poor organizational outcomes in terms of quality of care, it is actually less. So patients are less, they are less satisfied, and there are also more complications. So these are very serious consequences. So we developed a model, and this model has actually two processes that are shown here. A model to understand the drivers of burnout. And you see here the battery that I showed before. So it's about mental energy. When you are high in energy, you are engaged. When you're low in energy, you are exhausted and you are burnout. And the idea is that there are some aspects in the work situation that are driving that process. And as we have just seen in the slide before, there are negative outcomes in terms of health and in terms of work performance. So what we see is that burnout is specifically driven by high job demands, like, well, one of the most important one is work pressure, for instance, and low resources. Low resources, an example is low autonomy at work. I will give a little bit more detail about resources and job demands in a minute. But also leadership and personal resources are important. So some people are, for instance, more optimistic by nature. And when you are more optimistic by nature, workload is probably not so much a problem for you, because you think, well, it's a high workload, but I can handle that. Or when you are optimistic and you have a lot of autonomy, you can use that autonomy even better than people who are pessimistic. So the person is also important. Well, this There is a lot of studies, overviewed, meta-analysis, and this is a very simple representation of the model, but this model is very often used in occupational health psychology, and it's validated in several studies all over the world. So what are the typical stresses also in healthcare? Well, when it comes to quantitative demands, it's about the amount, so the amount of time and the amount of work, so the pace of change, the number of patients you have to work with, or you have to deal with, and the idea that you have to be stand by all the time. This is considered to be, and these are empirical results. I'm not talking about something that we think, but we know that this is driving burnout. Qualitative demands, emotional demands, like dealing with death, dying, with difficult relatives, patients that are demanding. This is all emotional demanding for people in healthcare, but it's also part of their job. So these qualitative demands, they are more or less implicit in the job. You cannot say to patients, okay, be nice to the doctor and don't suffer and don't complain. And so they have to deal with it in a way. And also mental demands, having to process a lot of mental information. But most importantly, probably are the organizational demands, in particular red tape or bureaucracy. This is a huge problem in the Netherlands, and I'm sure that it's also a problem in Italy. And in the Netherlands, we even have a program that is facilitated by the government, how to reduce unnecessary bureaucratization. Because we have a shortage of doctors and nurses, and the doctors and nurses that are working, they are spending up to 30-40% of their time in doing unnecessary bureaucratic work. But also organizational change, interpersonal conflicts, so problems at the shop floor with each other, role conflicts, so you're not certain what is your responsibility, what are your tasks, and harassment at work, so intimidation and so forth. And then we have resources, so the good guys, so to speak, the things that should be in place, and if they are not, then they are a risk for burnout. Support from your colleagues, a good team climate, a clarity of the role, so there is no conflicts here, but it's clear what you are responsible for, what you have to do, you know what kind of job you have to do. Having recognition from the patients, but also from your colleagues and also from your superior. And psychological safety, so feeling safe in the sense that being able to express whatever you want to express without fearing the negative consequences or retaliations. So feeling accepted in the group and feeling cared for by the group and feeling taken seriously. And then the work itself, so control or autonomy, it's very important. Can you take a break whenever you want? Can you decide to have some tasks maybe later because now you are not very fit to do that? So this is all control. Does the job fit to what you want and what you can? So this is the person job fit. Task variety, using of skills. Can you use your skills, or is your job monotonous? And have you a say in decision making? And then the organization, is the communication fluid? Does the management know what is happening at the shop floor? Do the workers trust the management, the direct supervisors, but also the top of the organization? Psychological climate is a good psychosocial climate. That means that do the workers feel, the employees feel, the nurses and doctors feel that the organization is caring for their well-being, or is that not the case? And that's what we call psychosocial climate. Value congruence, my personal values, are they similar to that of the organization? And are there procedures in place that are fair, instead of that there is a kind of nepotism and things going on that you cannot control, and you feel that the procedures are not fair and not equal to all people. And then we have the growth resources that make people learn and develop at work so that they can advance in their career. And one of the major things is also having performance feedback. And then the personal resources and vulnerabilities. So resource, the positive things, and vulnerabilities, so to speak, the negative things. So these personal resources like emotional stability, self-esteem, optimism, etc. These are all buffers for burnout. An important one is the last one, self-management, boundary control, means that, in simple English, saying no. So managing your boundaries, what you do and what you do not. And people are burnout typically go over that boundary because they think it's important. It's important for the patients to do, and for my supervisor, and they continue, and then they burn themselves out, so to speak. And also perfectionism. You do not tolerate any mistakes. You want to do always everything to the best. Workaholism, which is the kind of obsession with work, a tendency to work hard and very compulsively, so you cannot not work, so you always have to work. This is very bad, and it is also a predictor for burnout. External locus of control, this refers to the idea that you feel that your life is controlled by others, maybe by luck, maybe by a higher spirit, maybe by your boss, maybe by the government, but you cannot do anything about it yourself. And rigidity, so you're not flexible. So when there is a problem, you don't know how to deal with that because you only know one solution. So these personal resources and vulnerability also play a role in combination with the demands and the resources. And then finally, we have leadership. And leadership is important because it may satisfy basic psychological needs. And these are represented in the left. So people, generally also people who work, want to do meaningful work. They want to grow and develop. They want to relate to other people, and they want to have a certain amount of autonomy. And these are called in psychology basic psychological needs, because everybody has these needs, and you don't have to do anything about it. It just comes with your being human. And to the extent that leaders are able to satisfy these basic psychological needs at work, the workers, the employees, can either be engaged when they are fulfilled, and when they are frustrated, they are burned out. So let's have a look. So we can now distinguish engaging leadership and disengaging leadership. You can also see as it is a kind of continuum. When leaders are inspiring and making clear that what you do is important, because it's also important for the organization, for the patients, for your colleagues, for everybody, and they actually inspire you to do that. This is a good thing. It gives you energy. But when your leader is demotivating you and saying, well, it's not so important, your contribution is not important to the whole thing that we want to develop here, then it might lead to burnout. The same for growth. Strengthening by delegating tasks, by challenging workers, that's a good thing. And not delegating anything and not challenging, just ignoring people, that's a very bad thing to do, and it might lead to burnout. When it comes to relatedness, leaders should connect people, solve the problems between them, build a team, instead of isolating people or taking sides in a team and not working towards making it a group, but seeing it as different individuals. And then finally, by empowering, by giving voice to the workers, you stress their autonomy. And the opposite is coercing. So you just tell them you have to do this, and I'm the boss, and I decide that you have to do it in this and this way. And this is not a very good thing to do. So you see, also leadership is playing a role here. Finally, and maybe even most importantly, what to do? What can we do about preventing burnout in the workplace? Well, there are a couple of, quite some evidence-based interventions. And important is that these interventions, they focus on different levels. You have the individual level, and of course, conceptually, this relates to the personal resources. So you are actually building personal resources because they buffer the effect of all kind of things that happen in the workplace, and you can do that at the individual level by, for instance, workshops, by instructions, by training. For instance, cognitive restructuring. There are training programs that learn you how to look at the glass that is half full and not half empty. So the way you look and you interpret reality, you can learn people how to do that in a more optimistic way, for instance. Also, relaxation and mindfulness have been, there is evidence-based material. There are studies that show that relaxation and mindfulness help in reducing stress at work and burnout. Also, time management. Remember that this skill is important because there is a high work pressure, there's a high workload, so you have to deal with your time. And work-life balance is also an individual approach. Of course, the organization can do something about it, but ultimately it's also an individual issue. And then you have team conflict management, social support, coaching, leadership, having clear tasks and responsibilities, so it's more about what you do, but also in the area of the workers themselves. You can do some training, or what is called job crafting, where you look at what is the contribution of each person to the team, and how can we solve that puzzle in such a way that the tasks that have to be done match optimally with each of those team members. What are you good at? What are you motivating for? And that's exactly what you can do and you are responsible for. And another person is doing something else. And being in a conversation, in a dialogue, and there is a method also for doing this, you can have a kind of optimal division of labor in a team, so to speak. This is called job crafting. This is one of the techniques that you can use. And then at the organizational level, it's of course important to monitor how are my employees doing. What is the level of burnout? What is the level of workload? Do they feel autonomous in their job? Do they feel that they get support from their colleagues and from their supervisors? This is important to know in order to strike the right measures. And provision of services. Hospitals usually have all kind of HR instruments that can be used, for instance, e-counseling, but also career management skills training, etc. So things that an organization can provide. And then what is important is an open and accepting culture that tells people, okay, burnout is a kind of risk that everybody has who works in this profession. It's not that you are a weak person. It's not that you are not fit for your work. It's something that can happen to everybody if at times it is too busy and there are things going on in the workplace that are beyond your control, and we can help you to prevent that, or if it happens, we can help you to come back to work again. So there are various systematic reviews, many of them also related to physicians and healthcare workers, that actually show that this kind of interventions work. There is, well, you can have several conclusions. I would say there is one a meta-analysis that is most recent, but it comes to this kind of conclusions. First is that there is, at least in the Netherlands and probably also in Italy, a large intervention industry. That means that there are a lot of coaches, therapists, trainers, counselors that offer services, but there are not so much controlled intervention studies. And as you know, for a controlled intervention study, you need an intervention group, a control group, a pre-measure, a post-measure, and it's very complicated, and there is not so much good research. But the research that is there, most focus on the individual, not on the organization, which is also kind of logical, because individual interventions are more easily assessed than organizations, because you have to compare organizations, and well, this is quite complicated to have 5 hospitals that have a particular intervention and 5 hospitals, similar hospitals, that don't have that intervention, and then see how that works in both. This is more complicated to do technically and practically. Burnout interventions in general, and this is the good news, they have a small effect, a positive effect. And the bad news, you could say, is that the effect is relatively small. But it is consistent across different groups and across different studies. And if you have an organization, also a small effect might in the end pay out. Particularly relaxation, mindfulness, and these cognitive behavioral interventions, these seem to be most effective with mild burnout symptoms. And unfortunately, there is no consistent proof for the effectiveness of interventional burnout. And you should remember that it's also difficult to kind of define this. And I showed that in the Netherlands and in Sweden, there are generally accepted diagnostic criteria. And using these criteria, is it possible to describe and to isolate this group of burned out individuals who have really that burnout disorder? And in many other studies, there is not a clear definition of that group. So that's the reason why you don't find so much effectiveness for clinical burnout interventions. And finally, the results of the interventions are generally compatible with the GDR model. That means that decreasing demands in general and increasing job resources and personal resources has a positive outcome. So this model is also good in, let's say, summarizing and visualizing what kind of demands and resources are actually good if you have interventions. So you have to work at that at the same time. So concluding, the take-home message, well, burnout is, I would say, a modern affliction. So it has to do with the way we organize our work in today's society. It refers to 2 things, to mild complaints, but also to serious disorder. And these 2 are very often mixed in the discussion. It can be assessed by a questionnaire and by a clinical interview, 2 things. And in this clinical interview, questionnaires can be used as well, but the basic is then the clinical interview. It seems to be on the rise, also in healthcare. So healthcare, many healthcare workers, relatively speaking to other branches of industry, suffering from burnout, complaints at least. And it results from job demands and lacking resources, both personal and organizational one. And it can be reduced by evidence-based interventions, which is actually the good work. And it can also be prevented, or should be prevented, at different levels. So it's actually not enough to send people, your employees, to, let's say, a time management course, and then on Monday they come back in the same work situation. where there is no autonomy, where there is no support, where there are conflicts in the team. So there should be, ideally speaking, a combination of individual, team, and organizational approaches. So this would be the best preventive strategy. So I hope that you had a little bit of glimpse and an idea about burnout and recent developments, and how burnout in healthcare can be understood, and what we can do about it. And well, so far I would like to thank you for your attention. And as announced before, it is possible now to ask some questions, and I will see if I can answer those. Thank you very much once more.
Thank you, Professor Vilmar Schofeni. Grazie appunto for this overview, this complex all these aspects that you mentioned. There are many things that have been related, and many things to put together. Allora, non so se switch sull'italiano, e quindi ringrazio appunto il professor Schofeni del suo intervento, di questa panoramica. Avete visto appunto il concetto, diciamo, l'escursus è molto ampio che è stato fatto, quindi insomma, ecco, volendo chiaramente si potrebbe approfondire molto di più, però insomma appunto in questo tempo è veramente un overview molto, molto ampia, e quindi a questo punto io chiedo a voi se ci sono delle domande. Ho visto solo una domanda finora che chiedeva la possibilità di avere le slide, e non so se su questo sono già stati presi degli accordi col professore, o chiedo direttamente a lui, o come di solito, insomma, come vogliamo organizzare questo aspetto.
Accordi non so se erano stati presi, quindi bisogna sentire il
Ok.
professore se...
Okay, Vilmar, there is someone who asked if it's possible to have the slides that you show.
Yes,
If
yes.
it's... Ok, perfect. Se ci sono appunto delle domande, ovviamente insomma è molto utile avere insomma, se avete delle curiosità, approfittate insomma della presenza del professor Schofeni, quindi magari insomma, o scrivete appunto dentro domande e risposte, oppure non so se è possibile anche dare la parola direttamente a chi vuole parlare.
Sì, certamente, se alzano la mano possono
Esatto,
essere...
quindi alzando la mano vi diamo la parola. C'è una mano alzata. Maria Grazia Petracca, possiamo aprire il microfono?
Sì, salve, buongiorno.
Buongiorno.
Mi sentite, sì?
Sì, sì.
Domando, ma ci sono dei test semplici che possono aiutare nella diagnosi anche non professionisti? Penso per avere a luoghi di lavoro in cui non sia disponibile del personale che può in qualche maniera testare il soggetto.
Che fate? Traducete voi o traduco io per lui? Traduco io? Io non sento però le interpreti, quindi a questo punto non so
Yeah,
se lui è...
I cannot hear the interpreter, actually.
Ah, ok. The question is if there is the possibility to have simple test to if there is no
Perché poi parlate sul canale italiano, quindi lui si deve spostare sul canale italiano.
vabbè, a questo punto forse faccio prima però a fare la traduzione io? Ok. Mi sa che se tanto è una domanda sola per il momento direi vediamo un attimo. Sì, mi pare che ce ne sono. No, the question is if there is a possibility to have a simple test to have an evaluation of burnout if there is no a specific office or people that take care about this aspect and measure, for example, burnout, if the single person can test or can.
Yeah, you mean if there is
yeah.
If I understand the question correctly, it is about a measurement. And I introduced this burnout assessment tool. Actually, the short form. So originally it were 23 questions, and then we made a short form which has 12 questions. It's very easy to use. So 12 questions. You read the question and you mark how often you have this kind of complaint, this kind of problem. And well, as I said, there are some norms available, and then you can see do I as an individual score in the risk group or in the high group. And it's important to know that this is not a diagnostic test in the sense that you can never have a psychiatric or psychological diagnosis only based on a questionnaire. It's the same with depression. You have a depression questionnaire, but it's not that you cannot make a diagnosis, because a diagnosis also needs some information about the context in which everything is taking place. But as a screening instrument, you can use it very well, and it's also used in practice in the Netherlands. We are now even experimenting with only 4 items, so we're trying to reduce the number of items. So there is a questionnaire that you can use, and it's also for free, so you can log into the website that I presented before, and it's in Italian as well. So
volevo solo
magari...
ringraziare. Thank you very much.
Sì, magari possiamo mettere in chat, lo posso fare anche io, il link al sito che diceva appunto il professore, e quindi ovviamente appunto io sono tra l'altro molto d'accordo, quindi chiaramente a livello orientativo, no, è possibile fare diciamo un'autovalutazione, ma è chiaro che poi nell'interpretazione e comunque insomma anche diciamo non si può considerare ovviamente un vero e proprio assessment. È molto importante avere delle norme di riferimento e avere appunto no, diciamo in teoria appunto bisognerebbe misurare anche poi degli aspetti legati al contesto di lavoro, no? Per avere una visione un po' più chiara poi del problema. Comunque adesso metto magari il link. C'è un'altra domanda. There is a second question about the use for intervention of Balint group. I don't know if you know this kind of groups, if they're used and also in the Netherlands. And what is your opinion about?
Yeah, what I understand, what I know is that Balint groups already for a long time, they are kind of support groups for professionals that they organize among themselves, follow a specific procedure. I think this is an example of a support group that you can organize, and that I don't know any specific research that is showing that Balint groups have an effect on burnout, but I can very well imagine that when you know that it is that social support is very important, and that people can give you tips and tricks how to deal with problems and issues, and how you deal with that personally. You can learn from each other in these kind of groups. Then it's very reasonable to expect that there will be a positive outcome. But to be honest, balance groups in the Netherlands were very popular until 10 years ago or so, and then the last 10 years there is not so much attention for that anymore. I don't know why that is, but maybe it's different in Italy.
Yes, I think it is the same in Italy. Some years ago they were quite famous and used also together with the self-help groups, but now not so much. Ok, I put in the chat the link, ecco, dico per l'italiano, ho messo il link al sito, e su questo sito potete trovare appunto, oltre al diciamo anche a delle pubblicazioni su questo nuovo strumento, il Burnout Assessment Tool, appunto trovate anche la versione italiana. Appunto io mi sono occupata personalmente poi di validare questo strumento, quindi eventualmente ecco, potete anche contattare se siete interessati rispetto all'utilizzo.
Thank you.
Mi pare che c'era una seconda domanda sempre su questo argomento. There is also another question on the same topic about questionnaires that is written in English. I don't know, Vilma, if you can. That
Open
is
the
the
chat.
same. There are some questionnaires for psychologists to measure burnout. I only know the burnout event. I think I can
There's some
imagine the
questions for
Maslow.
psychological to measure burnout, you know.
Yeah. So
yeah, well,
it's the same.
as I said, I would recommend that burnout assessment tool because it's more modern, it's for free. There are better cutoff scores, and there is an Italian version, and Chiara just put the link, and you can download the paper then.
Ma lo vedete? Datemi conferma, perché vedo una persona ha scritto che risulta disabilitata la chat. Io ho scritto, non so se arriva solo agli organizzatori, se no la scrivo in questa sezione delle domande. Ditemi, chiedo a Roberta.
Maybe I can, wait a minute, I can
Sì,
share.
ai partecipanti non è arrivato il link.
Allora magari lo metto in una risposta, però poi non so se è visibile per tutti o solo la persona che ha fatto la domanda.
Allora, no, loro dovrebbero riuscire a vedere la risposta.
Allora, ho inserito il link, datemi conferma per favore se vedete. Se la vedete, l'ho messa nella risposta ad Angela Orti, però credo che sia visibile a tutti. Datemi conferma per favore. E poi passiamo magari all'altra domanda appunto di Giulia Cantonetti, che se magari apriamo il microfono, non so se c'è da abilitare il microfono.
Okay, do you hear me?
Yes.
Sì, sì,
Okay.
sentiamo.
First of all, thank you, Professor Schofoli, for this overview. I'm a PhD student, and this is valuable for us to further delve into all the elements we saw today. What I would like to ask you is, you explained us the two approaches of psychology, that is complaint, and medicine about the disorder. What is your personal view of these after so many years of research? Especially about intervention in organizations. Should we consider the normal view of it, the psychological view of it, and what can organization do when it comes into disorder?
Yeah, I think it's important to note that the disorder is very seldom. I mean, it's maybe 3 or 4% or so of the people, maybe even less. So this disorder is not very typical. So that means that in organizations, it's much better to focus on the prevention of these more mild burnout complaints, because they might translate eventually in this kind of disorder. So I think it is important to invest as an organization in also in healthcare in the prevention, and that actually starts with monitoring how the level of burnout is in the organization, but particularly also in particular teams, in particular wards. So because there are often very much differences, and in my experience, and I'm also talking as a consultant, the team and the team leaders, the supervisors, they are very important. So when you focus on prevention of burnout in organizations, you should focus on teams, and give teams also the possibility and the information to work on their own solutions. So when there is a conflict in a team, or when people in a team feel that the climate is not very well, or that there is not so much support, or that the team is feeling not very efficacious in their performance, then very often the team also knows how to solve it, or to ask for support for HR or for somebody else. So in my view, teams are very important for prevention of mild burnout symptoms, and that's where it all starts. By the way, I shared can you see the shared burnout?
Yes, we
Yeah.
can see the share screen.
So here is this shared screen where you can it's actually here in Dutch, but I can also show it you in English.
Sì, allora si può scegliere la lingua, e poi all'interno del sito trovate praticamente sia i test che appunto le pubblicazioni.
And you see manuals in English and in Dutch, and here is the questionnaires in all languages, and we are looking now for Italian, and whoops, here you have the Italian version. So you can download it, and it's very simple, and it's the total questionnaire, and here with the asterisks, this is actually these are the short versions with the asterisks. So you just leave them out, and then you have 12 versions. So this is it looks very like a lot, but eventually there are only 12 that you can take care of. So that's how it works. And if you want to have more information, for instance, you want to learn more about publications, then here are publications 21, 22, and you just can click on it. So when was your publication? Yeah, it was.
Yeah, it's no, 22 and
22.
Yeah, and
well, and he said, oh, here.
Okay, one is here. Yes,
this one, Italian.
This is the short one, the short version.
Is well, it's very easy. So you go to the website, you click, and then you find your Italian version. Maybe there is even a lot of figures. Oh, I thought maybe there is here's the items. So it's easy, even in Italian. Okay, that's what I wanted to show.
Non so se ci sono altre domande, non mi pare siano arrivate altre domande in chat, insomma nella sezione delle domande e risposte. E non vedo altre mani alzate. Direi che se non ci sono altre domande possiamo chiudere qui, che dite? Io ringrazio ancora il professor Sciofeli per il suo contributo, per la presentazione. e tutti i partecipanti, ovviamente. Ringrazio il Consorzio per aver organizzato questo webinar.
Okay, thank you very much for having me.
Grazie a lei, buongiorno.
Arrivederci a tutti.
Bye bye.